So dealing with family, what do you think about allowing them to watch the resus or allowing them to step out, or should it be depending on the situation, what they're comfortable with?
So I think talking to the family and explaining what you're doing so there's no surprises, but then giving them the opportunity to see the resuscitation efforts play out is actually beneficial to their recovery from that traumatic event. I think there's some evidence to show that. If it's something they want to do, obviously don't force them to watch. But there has been studies showing that it has better rates of recovery for the family.
So let's say in the rare circumstance, this patient is in a shockable rhythm. How do we calculate the dosages for the defibs?
So that's 2 joules per kilogram for the first shock, and then 4 joules per kilogram for every subsequent shock after that. And you round up on your monitor, whatever it ends up being.
Always rounds up because sometimes there's large jump. Let's say you calculate 50, then the next available one's 70 theoretically. Is that like a detrimental effect if you're causing that much energy when technically you only should be giving 50? Is that detrimental?
No, especially if the one after that is 30, then you're underdosing, less chances of terminating that rhythm, less chances of ROSC, poorer outcomes. So
Yes.
yeah, always go higher. And that's why we say that, right? So,
Let's say the patient is in a shockable rhythm and you administer 2 joules per kilogram, then they're still in the rhythm. So you administer 4 joules per kilogram. So what does that mean from an antiarrhythmic standpoint?
so after that would be, administering either lidocaine or amiodarone, being recognized as equivalent medications in this patient population. And so for amiodarone, we're going to be giving 5 milligrams per kilogram through the IV or IO routes. And lidocaine, we're going to be giving 1 milligram per kilogram, also IV IO, and we can repeat each drug once. So for a total of 2 doses. Yeah, so it's going to be our administration for that.
Is there any superior antiarrhythmic? Because we hear this debate to the end of time, amio versus lidocaine.
So in the adult population, it's been determined that they're equivalent medications. I don't know of any high quality pediatric literature for these antiarrhythmics, though. I assume your sample size would be quite small, but that'd be something to look into for sure.
And that's exactly what you said. Obviously, our medical directives are designed based on the best practice guidelines and current evidence. And that's why it's currently written like amio is equivalent to lidocaine and lidocaine is equivalent to amio. And it's all based hospital discretion. But like you said, like one, pediatric population is probably unlikely to be in a shockable rhythm, and 2, unlikely to be giving antiarrhythmics. So that's why the sample size would be small. But yeah, it's definitely interesting to look at. I'm going to loop back to what you said earlier, because I think this is a key thing to look at. So dealing with family, what do you think about allowing them to watch the resus or allowing them to step out, or should it be depending on the situation, what they're comfortable with?
So I think talking to the family and explaining what you're doing so there's no surprises, but then giving them the opportunity to see the resuscitation efforts play out is actually beneficial to their recovery from that traumatic event. I think there's some evidence to show that. If it's something they want to do, obviously don't force them to watch. But there has been studies showing that it has better rates of recovery for the family.
I think it's key too that just from a human side of things, and they're patients too,
Mhm.
worst they would ever experience. And I believe just from saying, like, hey, I'm Ryan, I'm going to come talk to you. I'm going to do everything we can, and I'm going to keep you updated with everything I do can help a lot. I believe there's some evidence to say you have one distinct person that talks. They're supporting them. They're answering questions. They're obtaining a history, and they're just there to support them, depending on your resources. But how important would that be?
Yeah, that's so important, right? It's such a chaotic and scary thing for them. But if you can explain what the procedures you're doing are like, and how the arrest is progressing, just, taking some of that chaos and guesswork away, I think would be really beneficial for them.
I was happy to see that and kind of reviewing this literature for preparing this, and that was supportive to see. And it's a good takeaway. If we have the resources to do it, always have someone designated to talk to the family. And we can even do that with adults. Doesn't necessarily have to be pediatrics, right? It's, hey, my name's Ryan. I'm going to be with you this whole time. I'm going to answer any questions. Let me know what I can do for you. Like that's
Yeah, I
good.
think that's great. When you have the people, sending one of the medics to go and give the family an update and having that point person be there is excellent. It's a really good point.
The last couple of questions. What's this PRIME trial?
Yeah, you tell me about it. I actually don't know about it much.
So this is interesting because it ties into what we're talking about.
Mhm.
So if we know there's a delay in epinephrine, that is detrimental for adult populations and the pediatric population. So they're testing this right now. Basically, PCPs and ACPs have a designated standardized IM injection where they just give the intramuscular injection of epinephrine. So that mitigates delays. You don't have to think about the dose, and overall, any level of care paramedic can do it. So they're seeing outcomes based on it because we know, again, it may be hard to get an IV. We have to get an IO, and you have to figure out that math. But if you just take away all that decision, any level care paramedic can do it. Let's see what it does for outcomes. I suspect it'll have positive impacts, but obviously we don't know until it's rigorously done and performed and analyzed. But yeah, that's currently underway in certain services in our catchment area.
Oh, that's fascinating. I mean, I wonder what the, relative bioavailability of it would be, like intramuscular, especially in intra-arrest state. But, that's going to be a part of it. Like, we're to answer that question. So that's exciting. Yeah.
Indeed. I'm sure they'll do sub analyses, right? If it's a PCP crew, we'll see what the dose did and how it affected their outcomes. Then if an ACP crew is on scene, then they get an IV and IO and subsequently administer cardiac epi. So it's a very good trial and it's a brilliant idea. So I'm very excited to see where the results go with that.
Yeah, no, it's great.
Last question. What percentage of pediatric population had a significant diagnosis that led to the cardiac arrest, or what percentage do you think is healthy prior to the cardiac arrest?
I would just be going off Gestalt answering this question and saying that most of these patients are going to be like healthy going into it. Most of them don't have an extensive medical history or any sort of congenital heart issues, which is kind of what we talked about earlier, right?
You're absolutely correct. It's like approximately like 85% have had no prior medical history before the event, which is like that. When I saw it, that shocked me. That's a pretty sobering thing to realize. The vast majority is healthy children.
Yeah.
So it's like what led up to it. That's the key to kind of obtaining that incident history. But if we look at the social determinants of health, obviously children that have low socioeconomic are disproportionately affected by cardiac arrests and like overall just a slew of different poor health outcomes. So that's where like community paramedicine comes in, and just good social supports and services can help diminish those adverse events and everything.
Yeah. It's a really important aspect of the system.
You have to summarize in 3 points the key takeaways of this podcast. What would you suggest to the listeners?
Yeah, I'd say, these are really stressful cases, but you can do a lot of good for these patients. So don't scoop and run, stay and play, focus on the airway management, focus on high quality CPR, get a good history, think of reversible causes, and double check your medications with your partner, I guess, or your biggest points for increasing positive outcomes and avoiding error.
Thank you so much for watching The 10A Show. This is separate from our professional roles and responsibilities. However, it's our main objective to try to discuss pre-hospital research, to disseminate knowledge, support education, and try to provide the highest quality evidence we can for the pre-hospital setting. Please let us know if you want any topics or questions covered, and we're happy to incorporate it.